So welcome everyone to our educational series focused on organ transplant. Today we are going to talk about kidney rejection. And we are grateful to CSL Bering for sponsoring this series. I'm here today. My name is Karin Hehenberger. I'm the CEO of Lyfebulb. I'm also a kidney transplant, kidney pancreas recipient. But I'm here today with two experts, a surgeon, Dr. McCune, McCune, who is the surgical director of the Pancreas transplant program at Columbia Presbyterian, as well as assistant professor of surgery. And I also have a fellow patient, Mary Wu, who is a two-time kidney transplant recipient and a Lyfebulb patient ambassador, who is advocating and working very strongly for many of us who are living with transplants. So welcome both of you, and are excited to get started. I wanted to just start out by asking Dr. McCune, what is kidney rejection? What does that mean? And are there different kinds of kidney rejections? And then I want to go to Mary and talk about your specific experience when it comes to rejection.
Mm-hmm. Right. I think the easiest way to think of it is the body's immune system identifies a threat in two different ways. One is the way that we're born with, and then the other is a way that we've adapted to. So things like we've talked a lot with this era of COVID of antibodies and how our body can identify a threat and actually target it. So when we talk about rejection in a kidney, there's two rejection types that mirror those two types of immune systems. So there's one we call acute cellular rejection, which can happen at any time after the transplant, but is most common in the first 3 months, and then goes down a little bit, and then it's most common then up to the first year. And that's a random rejection where your body is just identifying a foreign threat. And it's reversible about 99% of the time. And we see it happen about 10 to 15% of the time of anybody who gets a kidney transplant. The other kind is called antibody-mediated rejection. And again, this is our adapted immune response where our body actually recognizes that there's a specific threat and it targets it. And it's a more rare form of rejection. It's something that we see when people have developed antibodies to human things. So they've either had a transplant before, they've been exposed to human blood product, or they've been pregnant. And so they have some sort of reason to target it. And again, it's more rare, it's a little bit more tricky to treat. But the vast majority of individuals who are having a rejection episode is acute cellular rejection, and it's generally reversible.
Thank you. Mary, you have experienced rejection. Could you talk a little bit about your experience and when and how it was?
Yeah, absolutely. So I'm a two-time kidney transplant recipient. I was born with renal agenesis. My kidneys never fully developed. And I had my first kidney transplant at 5 years old after 2 years on peritoneal dialysis. That one began to fail by the time I was about 11 years old. And I received my second kidney transplant May 5th, 1995, pretty much 12 years old. And it was no more than 2 months later that I remember in the middle of the night waking up and I was I was burning up, severely hot, burning up. And I began to throw up blood and I was just pretty much passed out. I couldn't even move. And I was rushed to the emergency room and they determined that it was a rejection. Okay, so, and I remember staying in the hospital for a good week, at least, bare minimum, and heavy steroids. And it was a very just scary time, emotional time in general, because I'm like, oh, is this second transplant going to fail? Like, is this a chronic rejection? Is this all these emotions and thoughts were just kind of just going rampant in the brain? And then safe to say, like a good week or so after that rejection, it's been 27 years since my second kidney transplant. So that was definitely my experience with an acute rejection with the second transplant.
Fantastic, and congratulations. That's a pretty lengthy period with a kidney. And as you said before, it's a diseased donor kidney. So quite extraordinary. We heard in previous seminars that the average time maybe for a diseased kidney is more than less than 10 years or around 10 years. So that's really great. You know, what that was a dramatic experience, and I guess you really couldn't miss that something was wrong. Dr. McCune, you know, any other symptoms, anything else that people should be aware of? I would say first, if we talk about the acute setting, and if we go in specific and more specific in the acute setting, does it happen, you said, within the first 3 months? Is it mostly in the beginning, or is it toward the end of the 2 to 3 months? Where do these rejection episodes normally fall?
So they usually fall a little later in those 3 months. So it used to be, we had a very hard time telling a match. So when we talk about blood type, ABO, those kind of things, before we were really good at checking to make sure everything matched, we saw something called hyperacute rejection, which was as soon as we put a kidney in, it would turn colors and it reflected the body immediately rejecting it. And that's really not the story now. It's generally speaking, people are in the hospital, they receive all their immunosuppressive medications, they go home, and then in that early time period, we start seeing their creatinine go up. And because we're not seeing hyperacute anymore, there's usually not other symptoms of discomfort or those things that we saw before. Now it's literally just a lab value that goes up. It prompts us to do further investigation and we find a rejection.
Okay, so it's a lab value mostly as an outpatient,
Correct.
You know, versus the inpatient. Do you remember, Mary, when it happened to you? You were 12, so of course your parents were probably with you, or your siblings, or whoever, you know, your guardian. Anything in particular that you remember from that moment that could be helpful to our audience in knowing how to handle this situation?
Well, it's definitely much more so my parents' or family's story more than mine. A couple of things stand out to me during that time is, and I don't know if this is a correlation, I would love to get Dr. McCune's input, or but I remember after my second transplant, I was kind of like bubble girl. It was the summertime. I was told not to really go out. The immune system is very weak. It's very weakened. A rejection could very much be likely to happen. And there was this field day event that I really wanted to go to. It was tons of kids. And I remember saying to my dad, who was my primary guardian caregiver, who still is in a sense, I said, I really, really want to go to field day. That's all I want to do. I just want to be like a kid. I just want to be like everyone else. And he's like, no, and you shouldn't because your immune system. But I like pretty much begged him and we went. And so I had exposure to tons of kids outdoors and everything. I don't know if there's a correlation, but in my memory, I remember soon after having the kidney rejection, like literally, like I was burning up, and it was very like dramatic, where I ended up in the hospital with acute rejection. So, I mean, I don't know if I'm putting on the spot, Dr. McCune, but I'm curious, do you think there was a catalyst with that exposure to the kids or anything of that nature?
I'm going to say no, not at all. Like, don't worry that exposure did anything as far as the rejection episode. And I hope that nobody has allowed this thought to happen for a very long period of time. Like, we ask people to avoid crowds and those things more to avoid infectious exposures. Your rejection, most likely, considering the timing and how quickly it was reversed and how well your kidney has done since then, was probably one of these random rejections that happens in that acute time period. So I think the things that prompt rejection, especially in the long term, meaning not in the random kind of scenario, is missing your medications or whether you were sensitized or had antibody preformed to it before. But again, if I were a betting woman, I would think you had that first kind I talked about, the acute cellular rejection, which is the random one that we can reverse pretty easily. If you really had an antibody mediated rejection, which is the only one that can be precipitated by, say, a viral exposure or something like that, then I wouldn't think I would be hearing the story of a kidney that then lasted 27 years. So I think you did nothing wrong. You should be a kid. You should have done the things that you were doing.
Yeah, and I think the time period is, I mean, this was back in 1995. I mean, the medical advances that we have now, and the knowledge and the information and the access to that is so much more different now than it was back in 1995, I just remember being told, these are the medications you take, you can't go out, you're just staying put, and that's that to avoid anything with your weakened immune system and the kidney rejecting or going to failure or anything of that nature.
This is so important, I think, to hear this for you, Mary, because when we talked before, you were mentioning this episode, and I was just thinking, I want Dr. McCune to really hear the story, because I think it had nothing to do with it, which was great that it's validated, and you don't have to feel that you did anything wrong. And kids out there and people out there should know that it's okay to interact with others, even when you have a transplant. That's the goal with the transplant, right? Is to try to thrive and live again as a person. We've talked a lot now about the acute rejection, but there's also the chronic rejection, which is more insidious, or it just takes longer. Dr. McCune, can you talk a little bit of what happens in the kidney and what happens in the body when that goes on? And are there any signs, any symptoms, or any lab results that one should pay attention to?
Well, the easiest way to think about it is a living donor kidney, which is our most successful type of kidney transplant, lasts around 20 years. So Mary is a very lucky individual in all scopes of life. But that 20 years happens as opposed to a normal kidney that lasts 70 years because of chronic rejection. And chronic rejection is really just the chronic kind of hit, scarring, and those things that happen because our immune system can't be shut down entirely. If we completely eliminated a recipient's immune system, they would have the equivalent of something like HIV/AIDS, where they were just getting sick and in the hospital over and over again. So there's a balance, and that balance is to allow a little bit of the kidney getting beat up over the course of decades in this form of what we call chronic rejection. And when we do a biopsy or look at the kidney under a microscope, what we see is just scar. So the kidney is just getting kind of a dull harassment by our immune system throughout the entire time it's there.
So, with that's the scientific reasoning behind it, and this injury that can happen over time. What do you do with chronic rejection? Is there anything that you as a medical doctor will do when you realize it? How do you diagnose it, first of all? Is it biopsy, or is it a lab result, or is it both?
It's both. What we end up seeing is, again, as you were implying, kind of this slow progression of a creatinine, the number we kind of use as a monitor for the kidney long term. We see it progressing up. We then do other investigation. We get an ultrasound. We do other things that are non-invasive, and it ultimately ends in a biopsy. And when we do this biopsy, we often will see scar with some of the immune cells infiltrating the kidney. And there's certain things we can do to prolong the kidney's graft life after that time period. So we may change people's medications a little bit. People who are currently on tacrolimus or cyclosporin, they're a little nephrotoxic, so we may switch you off of that. But it's not going to stop the chronic rejection. It's more going to prolong the longevity of the kidney. And so we kind of go into this, what I like to call duck and cover mode. So we do everything we can to get the most out of this kidney. But we also start to think of ideas of maybe it's about time to talk about the next kidney, or how can we optimize you so that you will be able to get your next transplant and move forward in those things. Because really the treatment options for chronic rejection are limited because, again, it's this just long-term scarring of the kidney.
Yeah. There are some drugs out there in the market, not in the marketplace yet, but in clinical trials that are trying to reverse or prevent rejection from happening. Is either of you aware of that, or are there clinical trials that you have heard of that are happening?
We have several different trials happening at Columbia at any point in time, discussing rejection, reversal of rejection, how to increase the longevity of the kidney. And I think that ultimately all of them surround around this idea that, each transplant has a lifespan that's only so long, and how can we just push it out a little bit further so that we get patients to a point before they need to utilize their resources to get another transplant. I think ultimately what we all hope the endpoint is transplants that are made to be immunologically inert, such that we don't have to worry about immunosuppression or all those things again. So things, kind of bigger than idea sciences of xenotransplantation, meaning grafts that are grown in animals and then put into us, or transplants that are grown so that they don't have any sort of risk that way, is going to be the long-term answer. But the short term is there's always going to be another medication where we're trying to prolong the graft life and get ourselves to a point where the kidney doesn't scar and end up failing quite as quickly.
Yep.
Mhm.
But I think, so Mary, during your now 20 plus years with your kidney, just talk a little bit about what your program has been. How often do you get tested? How do you live your life with your kidney? And has this discussion, rejection, ever been, a serious discussion with your physician, or also first with your physician, and then I'd like to just hear from you, since you're also an advocate among other peers. That's something that people are worried about.
Yeah, so I would say the core of answering your question is when I made the transition from pediatric to adult, because when you're pediatrics, like, you have parents or guardians that are at the forefront, they're taking care of you, they're managing, they're doing the management and everything. But when I made the transition from pediatric to adult, that is when there were no more kid gloves. That's when they're very nice to kids, are nice to the parents, or they're not nice to adults. And that was a huge reality check for me. But at the same time, that is what I really believe opened my eyes to how much we have to advocate for ourselves. As a kid, I remember going in armed with index cards. Remember, this was the 1990s. This was not like smartphone, cell phone era.
Yeah. You didn't have an iPhone.
Yeah.
Yeah.
So, but and so to this day, I will, so that was the core of where the advocacy came about. I see my transplant center about 3 times a year. I have, not gonna lie, I started with nephrologists, and then I went to a transplant center. I've kind of been everywhere, because to me, this is my body. I have to work with a team. I have to work together. It has to be collaboration. It can't just be, when I ask a question, this is the answer and there's no discussion or anything. So that is also that was very important to me. So I get my blood work done 3 times a year. When I go to the transplant team, how do I live my life daily? To the fullest. I work full time. I hang out with my friends. I go traveling.
Don't worry about field days anymore.
Yeah, no worries about field days anymore. And actually, it was a reminder recently. I heard from a friend, from somebody, that the greatest revenge, revenge is such an extreme word, but the greatest revenge you can have is just living your life, not becoming your illness, not being defined by it, but just it's a part of you, and then it's what you do going forward in the best of ways. So that's
I'd like to hear from Dr. McCune, because that's really fantastic. In my view, I see it the same way. If you've been given this opportunity to take on life again, and with someone else's organ, and you're now trying to take care of yourself, but you can't just live a life of restrictions and live a life in a hospital. As a surgeon, you fix people, but your goal with fixing a person, I assume, is that person is also taking on some risks. Or how do you feel about that?
Well, I think it's a mixed bag. When you become a transplant patient, you're accepted into a community, and I hope that as transplant surgeons and doctors and those things, that we make it a place where, when you have major life changes, you're supposed to call us. Like, we're supposed to be a part of your family planning. We're supposed to be if you go moving. I had a patient who was a big game hunter, went all over the world. He called me every single time he went out of the country to make sure the right things are happening. So that's part of my job, because most surgeons do a surgery and then it's over, right? And my job is to make sure people are being able to go back out there and live the life they were supposed to have. So I think that for kind of transplant as an idea and a community really is about, hey, I do this and I hope it's like a tire change. I hope you never need to see me ever, except for me to just check in and tap in when big life changes are happening.
But that is amazing, the connectivity you have with your patients, and that you care that much, that they probably feel that, right? That they can connect with you and they can ask you, because most patients probably just try to look it up on Google, or they see we're traveling over there, or what are the restrictions and what can I do to prevent anything from happening. And creating that feeling of a team and security is so very important. So congratulations, that's wonderful. It must also be better as a physician to be more part of the lives of the patients going forward.
I think so. Yeah.
Mary, we have a question from the audience. Any diet restrictions after your transplant? Have you changed your diet? You were so young when you got your transplant.
I really remember my diet before the transplant, in the sense of like no dairy, like limiting potassium and dairy, and just as much food items that work the kidney, that overwork the kidney. I wouldn't say that I have any specific diet after the transplant, but I would say I am very mindful of my sodium intake. I check the sodium intake. And I mean, I'm a big ice cream lover. I couldn't eat that before my second transplant, and so all hell broke loose after my second transplant. And I don't know, with my second donor, she was a 4-year-old girl. I was really into Carvel ice cream and cheddar goldfish for some reason. I don't know if that is any correlation with my 4-year-old donor, but anyway.
We've had that discussion, I think, on TransplantLyfe, which is the community platform. Do you gain any preferences or any from the donor? I don't even know, Dr. McCune, is there scientific evidence for that?
I think the world is full of mysteries, and I embrace them all.
Yeah.
And moving to New York and learning how to do transplant has made me embrace way more than that. So I think it's all fair.
Yeah, no, for sure. That's really great. So, as we talk about rejection like this, and you mentioned that, Dr. McCune, you mentioned that the acute is about 10% of cases, while chronic, you said, is much less. So what's the percentage of people who, through a transplant, who have chronic antibody-mediated rejection that is so significant that it needs to be, that it eventually causes graft loss?
Well, let me separate that out a little bit. We talked about acute rejection. Antibody-mediated rejection, I feel, is very rare, and it's more of a case-by-case basis. So people who have antibody are really the ones who are at risk for it. So again, if they've had something that exposed them, you'll be told this by your transplant surgeon before you go into it. And it can be anywhere from a risk of more like 20 to 40%, depending on how much antibody you have to your specific graft. Chronic rejection, as kind of a separate thing, is something that I think most grafts that have longevity end up with. Yep. So if you've lived a good life as a kidney transplant recipient, you will have chronic rejection eventually. And that's not necessarily a bad thing. It's just where your graft is going. And that's ultimately what will take most grafts.
That's kind of what I thought. And it's really important to separate those two, right? Because this chronic rejection is really the body's way of eventually, unfortunately, winning over the immune suppressants and breaking through. And you, as a pancreas transplant surgeon, I have to ask, because it's interesting as well. There you have two paths, right? You have the chronic rejection, but you also have the autoimmunity of the person who had type 1 diabetes and still does, I assume. Yeah. Anyway.
Absolutely.
Yeah.
And I think that the autoimmunity, most autoimmunity is fairly relieved after transplant, because individuals end up with so much immunosuppression. Certainly people who were type 1 diabetics with antibody, the vast majority of them have antibody if we test for it later, but how much it actually affects the longevity of the graft is probably very individually based. Certainly we've seen the autoimmunity take the graft back over, but much like other illnesses like lupus or those things, most people see a reprieve in them after they've been transplanted, but then there's the anomalous that don't.
Right. I think there was a study in Brazil showing that with thymoglobulin, ATG, right, you could cure type 1 diabetes just because you were, but then you also killed 10%. So that's not really a good.
Yeah, no, that's not a good idea.
Not a good idea. You know, I want to go back to the diet thing, because as you talk about chronic rejection, you talk about what the body is doing, this hyperinflammation and what is going on, you know, in many of our bodies and cause other things as well, in addition to rejection. So is there belief among the community, from you, Mary, from the peer community, the patient community, that, you know, anti-inflammatories or, you know, reducing the oxidative stress that is on the body, is there a following around there? Is that being discussed? And then back to you, Dr. McCune. I know that there are articles written about this, but how much do you place, you know, how seriously do you take that? Start with Mary.
So I'm actually not familiar, or I'm not, I don't really know that, to be perfectly honest.
Okay.
Yeah, I mean, I can just speak from my perspective and my personal experience, that it's after my second kidney transplant that I wasn't told of any specific restrictions, but just your typical things like, oh, watch your fat intake, watch your sodium intake, and all of that. Maybe that's something that could be encouraged more, and more of a collaboration with the transplant team, you know, thereafter, just as important as before a transplant. Yeah.
Anything from you, Dr. McCune, on this reducing inflammation?
I think diet and kind of that side of medicine is a very exciting field right now. And the idea of what we kind of call an intestinal biome, where you can almost predict what diseases somebody's going to have in the future by the intestinal bacteria that you culture from them. So I think that side of life is huge and needs to be explored and has a lot of validity in medicine. I think sometimes when we go down a path of something that's fascinating like that, it gets oversimplified by people who would like to market it. And so there's definitely a huge conversation around this by individuals that aren't necessarily ones I listen to as a surgeon, that I don't know how much validity is there. But again, wives' tales have a lot of truth because they've been around for so long. And again, I think that research is starting, but I wouldn't necessarily believe everything you Google on that one. And certainly a healthy diet and those things are always what we encourage, and anti-inflammatories and those things. But on the other side, there's also pro-inflammatory things that are showing to be really good for us. So I just think that we're still figuring that out, and we don't know everything on that one.
Yeah, knowing more about your microbiome, and then maybe addressing the issues that you have is probably the way to go. And right now we're just taking stuff without knowing what the base is. Yeah. So I think that's valuable. Any closing comments? I mean, Mary, you've been a long-term survivor of 2 kidney transplants. Any encouraging comments to our audience? You know, how can they continue and living this life that is somewhat, you know, you're making it sound simple, but you're still taking medication. You're monitoring. I mean, it's not every day is a happy day.
No. Yeah, and definitely, I mean, I think the biggest thing for me is, and I want to credit my family a lot for this, is growing up, it was like, I mean, this is going to sound terrible, but it's like, you live your life to the fullest. And I mean, I know that just sounds so cliche, but I was always raised like, just because you have health issues doesn't make you special or different from other people. You're just like everyone else, but it might be a little bit more challenging. And there's always going to be challenges. There's always going to be things in life, whether you're healthy or not healthy. And it's this too shall pass. And just to be an anchor. Like recently I had a conversation with a very good friend of mine. And I said, oh, what do you want to be? And she's like, oh, I want to be an anchor, because no matter what happens in life, you're still steady and you're still you, and you still stay true to you. and just enjoying. Don't let all the challenges stop you or let you forget about all the great and all this gift of life that you can just take on the world and do great things going forward to help other people and to do more for others.
Wonderful. What about you, Dr. McCune? Any advice to your kidney recipients out there, and how do they live their best life?
I think, you know, we're all in transplant for a reason, and we know it's not perfect, and so it's a new field as far as medical fields are concerned, and we're really trying. What the ultimate goal is to give you your life back. So whatever steps, whatever measures, whatever things we need to keep looking into, let us know, because ultimately that's why we're here. And if you do have this opportunity, as everyone here is saying, just make the fullest of it and go live your life, because that's what we hope for you.
Fantastic. So stay in touch with your doctors, your nurses, your social workers. Just be open and transparent. And share. I think that's important. If you want to share with your peers, you can go to TransplantLyfe.com. If you want, you should obviously stay in touch with your care team and your families, whoever are the ones who support you. I think that's one lesson that I've learned. I mean, personally, is that living a life of not sharing, which it is not good for anyone, is not recommended. The more transparent we can be, the better. And you know, in some ways, that's also not just good for the physical being, but also the mental being, because then you are not alone with your problems, and you have someone else who can listen and share, and that does relieve some of the stress and the burden that we all take on. And nothing is worse than being alone with your issues. So thank you so much, both of you, and thank you to the audience for all your great questions. And we will see you soon again. Bye-bye now.
Thank you. Bye.
Thank you. Bye.